Hey, welcome to the Healthcare Nation podcast. I'm your host, Rick Giannata, with our producer, Joe Woolworth. Joe, how are you doing today, my friend?
I'm doing well. Liking being in the new studio with you.
Love the new we're in Studio B now. I feel like, whoa, we've got more than one studio in this. This is called Stepping Up and Stepping Out. And I like it. Well, we'd love to hear from the audience if they like it as well. So that's the other piece.
Yeah.
So what's new and exciting on your side of the world? We got some great guests, good follow-up on the GOP presidential potential debate.
What was really interesting to me is how it was like, hey, not much was even said about healthcare policy. And even if we did say a lot, it's pretty similar between the two parties, which is a really interesting place to be. Because we're so polarized on absolutely everything.
You know, I think that when you, and we're going to get into the introduction of our guest in a second, when you think about the common denominator, right? What holds it all together? There's these, I would call them immutable things you just can't touch. One is Medicare, the other is Medicaid. Then when you look at pharma and drug, we talked a lot about that in the episode today. And then the nuances on the fringes, and there's a lot in there that impacts, particularly when you think about who votes. But the numerator on this is the more than a nuance between the individual candidates and the parties, and that is where you really have to get into the detail. And in the GOP debate with the slate of potential candidates, we didn't hear anything on healthcare policy. We really didn't.
Which is weird because in the past, I remember healthcare reform being such a hot button issue, and you're really interested in everybody's take. And not so much.
It's when you think about voters over 65 years old, it is always a key issue for that constituency. So it is surprising that it wasn't there. Now, all that said, it's still pretty early.
Yeah.
And I think we said this in our last podcast. I do think that there are candidates who are still figuring it out.
Right.
You know, and that's certainly Mike Pence, because of his previous experience in the Trump administration, has a much more developed policy perspective. Right. Same thing for the folks who are governors, Nikki Haley and Chris Christie. But the others, I think it could be more of the development.
Yeah. And I guess it's important to address the elephant who wasn't in the room.
Yeah.
And so there was a big lack on what many believe or most believe is the forerunner.
Yeah.
Former President Donald Trump.
Yeah. And I think we can all, well, we pretty much are moving forward when we think about this from an analysis perspective, as he's presumptive nominee for the GOP.
Did he say anything in his counter programming on X about healthcare reform?
I didn't unpack it enough to go into that level of detail, but we should do that. We definitely do it. But let's get to our guest today.
Yeah.
This is, I just want to tell you, it's not that it's a milestone, but I think it's important. We've got Andrew Barnhill, Head of Policy and Chief Government Affairs Officer for IQVIA, right? The world's largest clinical research organization. Andrew is he's a lawyer by background. He's a policy expert. He ran for political office in North Carolina. But the big thing is he's been on this show before, and he is back. And the reason he's back is he is, Joe, our resident policy expert. And I love Andrew. He's just a source of incredible information.
Yeah.
So with that, I think we're going to really talk about not only the announcement today, which it's Tuesday the 29th that President Biden made with respect to new initiatives with CMS and drug pricing, but also everything around the fringes with healthcare policy, not only for the current administration, but the GOP side. So with that, let's welcome Andrew Barnhill. Andrew, my friend, how are you doing? Long time no see.
Doing great. Always good to see you. Busy time with the start of the fall and winding down of summer here in Washington, but always good to be back and talk policy with you.
Well, great place to be. There's no doubt about it. When you think about fall in DC, fantastic. And there's so much going on there. But I just wanted to say one quick thing. You know, Joe, our producer, and I were talking, and you are our first-time second guest. So, you know, that's a big milestone for the Healthcare Nation podcast.
It's a great honor. I appreciate it. I guess everybody's excited to hear about public policy related to healthcare. So glad to do it.
You are now the resident policy expert. So we're going to have you on here regularly because a big part of the show, obviously, is keeping our finger on the pulse of what's happening in politics, policy, how it affects payers, patients, and providers. The 5 Ps. I've always said that. So great to see you, my friend. Listen, let's jump right in. This is Tuesday, the 29th. Obviously, the show's going to air after this, but big announcement today from the Biden administration. I thought, Andrew, let's just jump in with that, specifically on what's happening with the drugs that were announced for CMS's perspective. A big thing that President Biden is linking to both the IRA and Bidenomics. Tell us your thoughts on that. Unpack it for myself and the audience.
Well, let's give a little bit of background to what's happened first today. So this morning, the Biden White House unveiled the first 10 prescription drugs that will be subject to price setting or price negotiation, depending on who you are, how you wish to describe it, between manufacturers and Medicare and CMS. And this really kicks off in earnest the process that the Biden administration is attempting to try to lower the cost of certain prescription drugs at the counter for patients. This was a signature part of the president's Inflation Reduction Act, which was passed on a party line vote last year. And it gave Medicare, gave CMS the power to directly set prices for manufacturers for the first time in nearly 60 years in the history of the program. And the first rounds of these prices are scheduled to go into effect on January 1st of 2026. So what we saw today was the first list of those first drugs that will be considered. Now, there have been lots of speculation over the past 6 months or so as to which drugs would actually make that list. Some of those were accurately predicted, some of them were not, but today we got to see the list.
Yeah, and I thought the list, at least from my quick overview, diabetic drugs, Eliquis, some, clot-busting drugs, if I could characterize it that way, Scalera, I think, which is more in the rheumatoid arthritis, psoriatic arthritic conditions, psoriasis. So, I can't say there's a rhyme
There were
and
3 different categories. It
right.
was diabetes drugs,
Right.
stroke-related drugs, and then a little bit on the arthritis side as well. So that's where really where you saw them. We were sort of expecting there might be more in the oncology space, but there actually weren't.
Right. From the colleagues I've spoken with on the clinical side, they were, just as you said, predicting more on the oncology side and maybe the heavy-duty anti-inflammatories as well that are out there, Remicade, et cetera. What we see, though, is, and I want to hear your thoughts on this, really going after the chronic conditions is what it seems like. I mean, you mentioned stroke, but I think this is really on the preventative side.
Yeah, it is not entirely shocking. The White House has certainly had an interest in trying to combat pricing in the diabetes space since the beginning. There was a separate provision focused on insulin as part of the IRA as well. So this is something that the administration has certainly placed a priority on. And there's also been a little bit of a hesitation to touch the oncology space, certainly with some of the efforts surrounding partnerships of the Cancer Moonshot. I think there was more hesitation there, but certainly a focus in, what can we do about the cost of prevention and ongoing maintenance surrounding type 2 diabetes.
Right. And I don't want to draw a direct line to it, but I think without mentioning the manufacturers' names, you could see even in the markets today, some wobbly effect after the announcement.
You did, but I think to some extent, the analyst community is still not picking up on one of the issues that I think many manufacturers actually already realize. And we could talk more about this throughout our time, but that is, even though you have a list of 10 drugs, that doesn't just mean that you're only focused on prices changing for those 10 drugs. Essentially, if one drug in a particular therapeutic class makes that list for price setting, it's very likely that that is going to impact the price of other drugs by competitor companies in that specific class. So even though the markets might have just reacted to the set of companies that were most directly affected by this list, they really over time likely should factor in, how is this going to influence or impact other companies who may not be on that initial set of drugs.
Yeah, and I want to make sure that I'm feed this back correctly. There'll be market pressures also that will impact the pricing of those drugs that aren't on the list, but maybe are in the same category.
That's correct. I mean, think about it. If you have a you have a drug that is in the rheumatoid arthritis space and yours wasn't on the list, but it's, for the same indication, then it's very likely that you are going to get pressure because, the insurance companies are going to show a preference on their formularies for the drugs that do have the lower prices. And so then it's probably likely that, other drugs in that class will be pressured into reducing their list prices as well.
Yeah, and I want to stay on the Biden administration, and obviously part of this show we're going to talk about the GOP presidential debate that
Sure.
just passed last week. But along the lines of current administration and what they're doing, what about the other parts of the IRA and Bidenomics related to healthcare, aside from what we're seeing in pharma, although it's very important? Bring us up to speed on that, what you think are the key points, and what will stick, Andrew, and what do you think's got some traction?
Yeah, that's a good point. That there are a number of positive things, even though those of us in the life sciences tend to recognize the problems associated with this new price setting process. There are some really positive things to talk about. One of them is the administration really cracking down on what they have called junk insurance, which is closing some of the loopholes that allowed some insurance providers to develop products that really discriminate based on pre-existing conditions and try to force consumers into buying products with little or no coverage. So that's something they've taken a focus on. Another has been in the surprise billing space, particularly with hospital billings. The administration is focused early on and trying to draft some guidelines or rules surrounding surprise billing, and so we've seen that for the past year or two. Another has been, attempting to address medical debt. So the Consumer Financial Protection Bureau, HHS, and Treasury all work together to explore whether provider and some third-party efforts to encourage consumers to sign up for medical credit cards and loans were causing some problems that they could crack down on. So, medical credit cards and loans often, of course, are leading to higher cost without consumers fully understanding the risk. So trying to get to that is something the administration has focused on. And then the out-of-pocket caps, of course. So part of the IRA was the inclusion of a $2,000 out-of-pocket cap in Medicare Part D, which certainly will make a difference to Medicare beneficiaries in upcoming years. So those are a series of the things that you're starting to see. There's also a focus certainly on health equity and diversifying clinical trials. That's something that we've been front and center on in my capacity as well. So a number of things happening, but I would say out-of-pocket cap, surprise billing, cutting down on some of the junk insurance that's out there, and then, of course, the overall focus on prescription drugs.
Yeah, and the drug piece that you mentioned outside of the announcement today, is that going after the Part D, the donut hole piece?
Yeah.
So the cap would be related to that, because that's really important when you think about, folks who are on Medicare, the out-of-pocket costs, and that trough that you fall into at a certain period if you're prescribed some very expensive drugs.
It's significant. And so that's one of the reasons that you're seeing general support across the board for the Part D out-of-pocket cap. Manufacturers have generally been supportive of that as well. And this certainly will make a difference to a number of patients.
So let me shift a little bit and think about other policies and loopholes, really beyond Medicare. Are there other legislative actions or executive orders from the current administration that are out there, aside from what you just talked about, that are either tied to another bill or that we need to look at, from a different perspective because they may be hidden?
Well, indirectly, I think I mentioned some of the health policy highlights, but there's also a focus on drug shortages. So there are a number of pieces of legislation that are moving right now in the shortage space because we've seen some issues there, post-pandemic.
Supply chain related, right?
Supply chain concerns, also natural disaster concerns. So you're seeing a series of drug shortage bills, not that have passed at this point, but that are moving through the congressional process. Another thing that we have coming up right in September, before September 30th, is actually the reauthorization of PAPA, the Pandemic and All Hazards bill that we see that occurs on sort of a calendar. This is just a reauthorization of the existing bill. But within that, there are there are some protections and preventative goals surrounding future pandemics, but there's also some inclusion of language surrounding clinical trials, getting at some of those reforms. There's also some drug shortage language in current versions of PAPA. Of course, we haven't seen the final version, has not passed yet. It probably will at the very end of the day, September 30th. Right now, we're negotiating between the House and the Senate, but that's another piece of legislation where you're seeing some reforms in the life sciences.
I want to pivot a little bit on the topic and talk about innovation and kind of draw a red thread from there to, obviously what's happening in the private sector and what is influenced by some of these policies that are clearly, some will stick. There's no doubt about it. So the impact on innovation, first, when you think about reducing drug prices may actually hamper innovation on the pharma side. What are your thoughts on that? And especially considering that 4 of the 5, biggest drug companies are based in the U.S.
It's a significant concern. I think, we talk about how expensive it is to run a clinical trial, but for some reason that never quite gets through to many of our legislators or those in the administration. It's sort of taken for granted and not seriously considered. But when you're having to make tough choices as a manufacturer or a CRO, you really have to think about, okay, is this potentially going to be a product that is going to be forced into Medicare negotiation and we're not going to be able to recoup the cost from R&D? That's a real calculus that manufacturers are having to think about. We're already seeing a market competition that has driven some high discounting in several markets that are going to appear on CMS list, either in this one or in subsequent list of drugs. So that's already starting. Keep in mind, even though January 1 of 2026 is when the sort of full scope of this price setting will take place, manufacturers are already having to factor it into consideration. Another key question is, if net price is the starting point for negotiations, how low will CMS push prices? And then what will that do to the amount of money, the amount of dollars that are actually flowing through in research and development? Are there specific categories or therapeutic classes that are going to be more at risk? Are we going to see less innovation in the diabetes space because there are a number of drugs from that space that are on this list? Are we going to see more innovation in other categories? Those are questions that manufacturers are asking right now.
Really important points, without a doubt. Let me switch a little bit to the innovation in the really, I'd say, the provider payer space, and think about Medicare Advantage, the Blues, Aetna, Optum that are out there, impact on what they're doing, even ACO REACH, when you think about some of the new models that are out there in the accountable care.
Well, there's going to be a convergence of effects from, sort of the different payer channels. I don't think we know quite yet what the convergence will look like. And that's because we're anticipating scenarios, but it's very hard to do it more than 2 or 3 years ahead. And we also don't know, how long this process is going to get drawn out. There's a lot of litigation happening right now. There are discussions about potential injunctions to slow this process along. So when will payers have to make adjustments to their pricing practices? Will that be within the next 2 years, or will that be later? And by that point, will we see changes in the way manufacturers are operating that in some ways preempt the reactions that the payers are having to make? All those things I don't think we entirely know yet.
Yeah, I think the president even commented on the litigation that's already started and from some camps as kind of a signal that, look, I'm taking on the big issues. So we shall see. Let me change the topic slightly to what's happening in artificial intelligence, everything we've seen over certainly the last 18 months, ChatGPT, how that impacts clinical trials, I would say patient-reported outcomes, your world from a policy perspective on that side of the equation. What's happening in DC with respect to regulation in that space, Andrew? Because I think this is a topic we're only seeing a bit of the beginning, and the impact is really incredible. So a lot more to come on this. How is this going to play out from a policy standpoint?
Yeah, it's a good question. I mean, I think legislators are starting to learn what AI is, how it functions, what ChatGPT is. I think they're at early stages. I think some of the agencies are a little bit further along. We just responded, in fact, to an FDA inquiry. It was an FDA discussion paper asking a series of questions surrounding the use of AI in clinical trials. And so we just submitted that response and we're waiting to hear what the FDA says back. Our impression is that the agency is going to seek ways to incorporate standards surrounding AI and ML in clinical research. But I think we're at the very earliest stages of that now. A lot of manufacturers and CROs are starting to think about the security and protection of data surrounding the use of AI platforms. And many, for instance, have started thinking about, do we develop our own in-house ChatGPT-like tools to be able to keep all of that data protected in-house? So those are the types of questions that I think are taking place right now. There's both sort of the internal governance of a company. How do you make use of these tools for your own work and for your clinical trials, for instance? And then what are the regulators going to require of you, I think comes a little bit later.
Another part of it that is incredibly intriguing to me is when you think about synthesizing consumer data or publicly available data on individuals, what they put out there on, say, a credit report, or even in the space that goes into anything from, their own personal information all the way through to clinical and HIPAA-covered information. When you synthesize together, it could be an incredibly powerful tool for a patient profile for their health status. Any thoughts along those lines of where things are going in the clinical research space as it relates to that topic? And probably the corollary to that is it's kind of scary when you think about it. Is that getting any attention on the Hill?
I wouldn't say on the Hill yet. I think most of the focus actually right now is, inside the companies. We're thinking about how do we use these tools to empower patients who are participating in clinical trials, for instance. I think most of the legislative focus that you're seeing in the congressional committees is surrounding ChatGPT itself and who is using it, and sort of a governance from companies themselves and what can and can't Congress do to control its use. They're also thinking internally themselves, just like companies are. Capitol Hill staff thinking about how can they use ChatGPT and similar tools for their own work. That's the type of conversation that's, I think, happening right now.
Yeah, I think it's a really important one, and it's going to clearly take up, I think, a tremendous amount of space ultimately in the policy world, but even going over into regulation, the FDA, clinical trials, because I think there's such promise there.
Yeah.
So let me shift gears completely. Last Wednesday, we had a GOP slate of potential presidential candidates debating. I thought it was quite informative. Many would say entertaining. One thing that was missing, besides former President Donald Trump, I thought was a lot of discussion on healthcare and health policy. So I wanted to start with that and get your thoughts on what you thought about the GOP presidential hopefuls and where they stand on policy from the information we have out there as just a first swing at it, Andrew.
First, I think it's an interesting spot for us to be in, using this debate to reflect on the state of the Republican Party, because quite frankly, I think you and I both know that the presumptive nominee is former President Trump, and nothing seems to be changing that right now. And so the question becomes, when you talk about health policy in the Republican Party, do you talk about Trump health policy, or do you talk about, what each of these others have articulated both on the debate stage and in their own careers? And so that's one of the questions that I have to wrestle with a bit as we're thinking about, what does Republican healthcare policy look like for the next term? And as I sit down with my team and talk about planning, should Biden lose re-election, then what does that mean for healthcare policy? Do we think about it only in a Trump lens or not?
Yeah, and why don't we start there? I don't want to cut you up, but that's a great place to start. What do you discuss with your team if you thought, we've got a Republican in the White House?
Yeah. So it depends if you mean a Republican in the White House or Donald Trump in the White House. So previous Republican administrations and many Republican leaders on the Hill have tended historically to have a more favorable and friendly working relationship with manufacturers and many healthcare stakeholders, particularly in the life sciences, right? You did not hear a former President Bush talking about hitting big pharma, quote unquote, or doing things to specifically seek to harm individual companies. What you did hear, however, in previous Republican administrations is looking at how can you make reforms to some of the government programs, such as Medicare. That's how Part D developed to reach patients more directly or to incentivize free market approaches, right? The Republican Party changed under Trump. We still had sort of the McConnell wing that is still a little bit friendlier to manufacturers, for instance, but much of Donald Trump's rhetoric was, let's hit the industry, let's try to force negotiation, which actually doesn't sound that different from what you're hearing from current President Biden. When I say you're seeing similar health policy between Biden and Trump, that sort of throws people off who aren't in the health policy world a little bit, who come to me and say, oh, it's got to be worlds different. And I tend to say, not really. When you're talking about drug pricing, it's not. Now, having said that,
Andrew, let me just respond to one. I couldn't agree more. I could even see a scenario where former President Trump would say, look, with respect to pharma, big pharma, he started it. If you take a look and go back, all right, during his administration, there's no doubt about it. And I think that you could clearly draw the line from what's happened in the current administration. And folks would say, look, it started there. So I could easily see that, not that it's an argument, but that case being made.
Yeah, absolutely. So, what does another Republican administration look like? I mean, I think most likely that next Republican administration, if there is one in 2024, would be Donald Trump. And so you would see a continuation of some of the policies that are currently in place that were started by Trump and continued by Biden. If it is a more traditional conservative, a Mike Pence, a Tim Scott, a Nikki Haley, for instance, you will probably see a little bit less pressure on the manufacturers, maybe some rolling back of what you've seen under Trump and Biden. Again, that's a possibility because I don't think that, most of your rank and file Republican members of Congress are with Trump on the, let's hit pharma on price negotiation piece in itself. But you're right that noticeable absence in discussion around healthcare policy in the debate as a whole. I don't think it was one of the key issues that was driving the conversation. And they talked a little bit about foreign policy. There was sort of this big elephant in the room, not in the room with Donald Trump that really, drove much of the discussion. I do think it's hard to go entirely back, though. I think no administration can come in and say, we are going to wipe out reforms that, have been made under a previous administration. And I think, I have a lot of colleagues in the industry that keep thinking, oh, if we get a more traditional Republican administration, there will be some rollback of some of the provisions of the IRA. And I think the odds of that happening are pretty slim at this point. So what does the Republican field, look like right now in respect to healthcare? I think you would put, as I mentioned earlier, a Tim Scott, Mike Pence, Nikki Haley in one camp. You would put Vivek Ramaswamy in another camp with Donald Trump, which is interesting because he was a biotech CEO, but he's in some sense echoing a lot of the tone and language of the former president. And maybe it is because he actually came from the industry. He feels that sentiment a bit. And then of course you have Chris Christie, who's been, considerably favorable to the industry. Historically, you think about it as former governor of New Jersey. New Jersey is a significant pharma state. And so you always see whether they're a Democrat or a Republican, a more pro-pharma stance from those members. But again, I think if you're asking a political opinion from the debate, I think the most likely candidate or the presumptive nominee was not on that stage.
Yeah, two things along those lines. One is I think that you called out Governor Chris Christie.
Mhm.
His stance on Medicare, Social Security, I think if you look at the policies that are there, raising the eligibility age,
Sure.
changes, they're pretty substantive changes. And if that gets enough press out there, and again, you think about who votes, I don't know how that will play. So
Yeah.
just taking him out of the equation, I totally agree with you. There is definitely former President Trump, Vivek Ramaswamy, and then the rest of the field kind of split down the middle when you look at what's left over. One area, though, that I wanted to go into a little bit detail with you would be Medicaid at the state level and then Medicare in general. Can you comment on those two areas?
So the Medicaid has been an interesting debate and evolution among the parties. And I think we might have touched on this very briefly in our prior podcasts. And that is that, you saw vast majority of Republican governors or state legislators across the country prior to 2016, 2017, were very hesitant to support Medicaid expansion in their states for a couple of reasons. Largely, they made the argument that too much of the burden was placed on the states to be forced to fund a Medicaid expansion, so expanding the population that's covered actually by Medicaid. And so you saw during the 2014 and 2016 and a little bit 2018 cycles, Republicans campaigning fairly hard against Medicaid expansion in their states. We saw a shifting, and in some cases it was dramatic and some it was gradual, but it was still very fast from Republicans to be pretty much on the same page with a lot of Democrats on expanding Medicaid in their states. And part of that was because they discovered that there would be more federal support and federal dollars actually contributing in the formula towards expansion in their states. And part of that was just the changing moods of the individual electorates. But we saw some pretty much wholesale change over time within the Republican Party surrounding Medicaid. I remember it being such a bitter fight back in 2016, but it's just not so much the case now. So that's Medicaid. And so I don't think you will see too many Republicans coming out against expansion. However, the interesting thing is, particularly those who were governors, so Nikki Haley was a governor of South Carolina, for instance, they may be called to task on their prior positions on Medicaid back when they were the chief executives of their state. Maybe less Chris Christie, because I think New Jersey has a little bit of a different story on Medicaid, but that's something that Haley could be forced to deal with. Now, Medicare itself is where you're seeing a little bit more variety, both in the reforms surrounding Part D, where the individuals stand, and then things like increasing ages and finding other sources of funding within the government. So hopefully that's helpful.
Yeah, particularly on the Medicare side, I think that would be a polarizing issue. Absolutely, at the presidential level when you come down to the policy piece. Andrew, let me wrap things up with a couple of other questions. Do you think there are broader economic impacts when you think about the current administration's policies and a future, if it's a Republican or Donald Trump back in the White House, that will impact healthcare and the trajectory of what we're seeing in general terms with healthcare delivery and the policies? Any big economic impacts along those lines?
I think there's certainly a question about investment in healthcare, particularly surrounding R&D. How much do investors want to take risk with a changing market surrounding the pricing of therapies? And that's, there's a risk appetite question that I think we're going to have to see play out. And we're also going to have to see through time, how much do manufacturers and payers just adjust to a new reality surrounding Medicare price negotiation? Or do we see significant upsets in the industry that force a recalibration of R&D spend that ultimately changes investment that has a broader economic impact? Those are the questions of the next couple of years, I think. And, unfortunately, those of us that look several years ahead see a lot of writing on the wall for potentially negative trends surrounding some of the smaller biotechs and specialty manufacturers who may have, one or two products that they are, seeking to try to develop from clinical stage to market stage, where they're not getting a lot of support for investment, and you see some of that funding dry up. So those are questions that I think we have to deal with as a broader healthcare ecosystem over the course of the next probably 2 to 4 years, because you'll really start to see the market changing by the beginning of 2026.
Yeah, I think my experience and folks I've talked to in the sector, it seems like it's almost this bifurcated approach. You've got early startups,
Yeah.
which they're not getting the kind of funding that you certainly saw 24, 36 months ago.
Yeah.
And the valuation for what they have is a lot leaner. There's no doubt about it. And then you have later stage where, for whatever reason, they've become devalued to the point where folks are maybe more favorably inclined to invest because they don't have the valuation they had.
Yeah.
But
You're right.
but both don't equal to the kind of numbers we saw 24 months ago. And it's
Sure.
a much narrower field.
Well, the administration, I think, recognizes this. It's not that they are unaware of these realities in the market. I think it's that they have placed a greater priority on the cost of particularly maintenance medications and trying to focus on, you see with these drugs, your type 2 diabetes, your stroke prevention, for instance, and they are less focused on accelerating R&D for sort of some of the rare disease therapies and the like. And, I think that raises a bigger question for us as an industry and also as a society. Are we more concerned about lowering the cost of preventative and regular ongoing care for patients at perhaps the expense or the cost of some innovation, sort of further parts of the chain surrounding more advanced needs? Or are we going to say at some point, hey, we like our innovation, we like to have the latest and greatest, and we are not going to, put up with these reductions in cost that, require sort of a recalibration of our life sciences landscape? I don't know what the answer to that is yet, because I think it has to play out a little bit more, but those are the types of things that the public's going to have to wrestle with over the next few years.
Yeah, I also think that fragmentation, if you take a look at the consumer and retail side of things with Amazon and, the CVS coming into play, both a provider, payer, and this consumer, again, synthesized kind of model, which is very attractive to certainly Gen Xers, millennial folks. And then you've got, on the flip side, say, the expansion of Medicare Advantage and that. So a very different landscape with very different levers moving forward.
But I also, one thing that we didn't mention, and I know we're at the end of time, we're also likely going to see some disruption to the PBM model.
Yeah.
And in that sort of position in the landscape, we're finally seeing some questions surrounding PBMs on the legislative side. So stay tuned for some change there as well.
Yeah, and I think there's some innovative startups too in the space who are coming in and coming asymmetrically,
Sure.
absolutely going to make a dent in that. Final thoughts, prognostications, predictions on policy, health policy specifically across the board that you can share with the audience?
Key things, I think through the end of this year, we're going to continue to see some focus on preparation for future pandemics with the PAPA reauthorization and several other bills in that space, focused particularly surrounding drug shortages, which is a significant concern right now. We will see the continued implementation and fighting surrounding the implementation of the IRA's price setting provisions. And then we will see the Biden administration attempting to argue that these provisions are wins that will help them in re-election in 2024. And we'll see what the Republican candidates do. If it's Trump as the nominee, we will likely see him taking credit for the implementation of some of the IRA's provisions. If it's another candidate, on that off chance, we might see some repositioning of the field in the debate a bit.
Let's timestamp that, Joe, for the future episodes. We're going to hold Andrew to his word and have him back. Andrew, great seeing you, my friend. Thank you for sharing your expertise, your perspective with our audience and with me. And take care of yourself.
Glad to do it. Always good to see you, Rick. Have a great one.
Take care.